Right, it's 7 o'clock, so I'm going to make a start. So welcome to our Making Life Easier with the Coloplast three-step approach, focusing on leg ulcers. So my name's Sam. I work with Coloplast as a tissue viability nurse advisor, and I'm joined by my colleague Charlie, who's also a tissue viability nurse advisor. She'll be supporting the chat, so any comments, questions you've got, please put them in the chat and Charlie will be able to help with those. And I hope you enjoy the next hour looking at leg ulcers following the Coloplast three-step approach. So first of all, we're just going to cover the objectives of this session. So we're going to introduce you to the Coloplast three-step approach, which is a simplified framework, and it's to ensure that as clinicians, we're effectively assessing our patients and their wounds, preparing those wounds to healing, and treating leg ulcers appropriately to ensure they are on that healing trajectory and heal in as quick a time as possible. You'll learn about the simplified approach to wound healing, understand a bit around the costs and the impact of leg ulcers in the UK. We're going to have an overview of the latest leg ulcer recommendations from the National Wound Care Strategy Programme. And then at the end, we're going to leave you with the Coloplast three-step approach leg ulcer pathway. And I'll talk you through that when we get to that part of the presentation. So just looking a bit at the epidemiology of leg ulcers in the UK, it's well recognised, and we know that venous disease is the most common etiology of leg ulceration. A 2015 study found that at least 730,000 patients in the UK have leg ulcers. So that's 1.5% of the adult population have a leg ulcer. So when you think about that, you know, lots of people are affected by leg ulcers. It's estimated that this number has actually increased between 2012-13 and 2017-18. So that's looking at the Julian Guest et al. Data. We know that there are 1 in 170 adults have a venous leg ulcer. So those figures are really quite high, and we know that there's an issue with patients with wounds on their lower limbs not getting that right diagnosis, not having that wound diagnosed as either venous, arterial or mixed. And we know that we need to be improving that to making sure that our patients have better outcomes. When we then look at the financial costs of leg ulcers, so an average person that has a venous leg ulcer, it will cost £7,600 to treat that patient with a venous leg ulcer, and it can increase to £13,500 for those venous leg ulcers that don't heal. So when you're thinking of the NHS budget, we know that there's not going to be more money fed into the NHS, but that sort of money that we're spending on patients with venous leg ulcers that aren't getting the most appropriate care, it's really, you know, you can see where we could really benefit and get some more money to provide wound care. So now I'd like to introduce you to the Coloplast three-step approach. So this is the simplified wound healing framework. It's obviously got the 3 steps. So step 1, which is assessment. So it's providing that holistic wound assessment to ensure that you're defining those treatment objectives for the wound. Then we move on to step 2, which is that preparation. So we know that wound preparation is key to removing the barriers to healing. And in my clinical experience, it's often the step that's missed or is not given the most appropriate amount of attention that it requires, because by removing those barriers to healing, you're creating that optimum healing environment. And we need to do this to ensure whatever dressing or treatment we're giving that wound, it's in the most optimum condition to be able to progress. And then it leaves us on to our step 3, which is that treatment. So at Coloplast, we have a simplified portfolio of dressings to manage wounds of any depths and stages of healing. So with the Coloplast three-step approach of assess, prepare using All Prep Pad, which is our mechanical debridement. Again, I will talk about that in more detail as we go through. And then treating with our simplified portfolio of dressings with 3D fit technology. And again, I'll talk into more details as we go along. So first of all, we're going to look at that assessment. So what do we try and do with our wound assessment? We're trying to identify the cause of that skin breakdown. We need to know why that wound is there so that then we can ensure that we've got that right diagnosis and ensure that it's not going to break down again. We need to identify those associated risk factors. So we know when we're looking at our patients, we need to look at all different aspects of that patient to see what's going to make them more vulnerable to that skin breaking down. Our wound assessment also allows us to correct or treat underlying cause. So when we're thinking about those leg ulcers, it's about managing that circulation. So if we know we've got venous disease, do they need a referral to vascular? Do they need further treatment to ensure that circulation is optimized as much as possible? It's about controlling those wound-related symptoms. So again, when we think of leg ulcers, exudate often plays quite a problem with the wounds. And if that exudate isn't managed, what happens to that peri-wound skin is that exudate sits on it and it starts breaking down the peri-wound skin, and then that wound just gets bigger and bigger. If you haven't identified and managed that venous disease, then the vessels aren't working appropriately to move that edema. And again, that's just going to keep pouring out of those legs until it's managed appropriately. Preventing that skin breakdown, like we identified, that exudate sitting on the skin will cause further deterioration. And it also allows a good conversation with the patient to manage their expectations and have that open and honest conversation and provide psychosocial support and promote patient independence. So as we go through this framework, you'll see that it's a very simplified approach with those 3 steps. And actually, it works really well when you're looking at supported self-management, because patients can take over some of the aspects of the care, if not all of it, and to make patients independent and be able to manage their wounds gives them that bit more ownership of the wound. And like I say, as we go through, we'll look at that a bit more. So how often should wounds be assessed? So it's really important that we assess the wound in an acute setting every 2 weeks or every 4 weeks within a primary care and community setting. And this just isn't when you take the dressing off and looking at the wound. This is that really thorough holistic assessment. It's where you're remeasuring, checking, is that wound getting smaller? Is it getting bigger? Is the slough being removed? Or actually, have we got more sloughy tissue present in that wound? If that wound's changed drastically between dressings, then you would obviously do your holistic wound assessment sooner. But this is just a guide. And it is really important. The amount of times that I've seen patients whose wounds been deteriorating, but it hasn't been noticed because you haven't had that consistency of care, and that no one's gone back to think, oh, is this wound actually progressing? So it is really important, because if that wound's not progressing as you expect, then you need to be able to go back, because you might have missed something. Something may have been assumed, something may need redressing. So it is really important to go back and do that full holistic assessment. And if things aren't progressing, refer on to other specialists, escalate when things aren't going as you expect, because just letting a patient carry on with wound dressings that isn't progressing that wound can be very detrimental. So at this point, I'd like to introduce you to the triangle of wound assessment. So this is a wound assessment framework that was created with multiple specialists in wound care, and it's just to allow that really robust assessment to ensure you've covered every aspect of the patient, including that wound, wound bed, wound edge, and peri-wound skin. So it covers all aspects. So you've got the sort of light blue circle, that's looking at your social economic factors. Then you've got your person, so that's looking at things like their age, their lifestyle, their comorbidity, what their mobility is like, what medications they're on. And then you look at the wound. You look at that wound bed, that wound edge, and the peri-wound skin. And you need to look at every single aspect to ensure that you're doing that robust assessment. So when we look at indicators of underlying venous disease, there's lots here. I'm not going to go through each one, but we know those general signs of venous disease. So has there been a past medical history of deep vein thrombosis? Has there been lower limb fractures? Is there a history of venous disease? Are they presenting with varicose veins? And then you've got those visual signs, that ankle flare, varicose veins, that pigmentation and staining, that venous staining where you get the discoloration around the ankle area, eczema, dry skin, also just that pain and heavy feeling in the legs. So we're health professionals on this call, and we're often on our feet for hours and hours on the day. And sometimes you get home at the end of the day and you just have that, when you take your socks off, you can see that edema. And you do sometimes have that pain and heavy feeling in your legs. And those are those indicators of that venous disease. Also lifestyle, so obesity, if patients are physically inactive, stress. And when, like I said, nurses, we're renowned because we're on our feet all day, but occupations also play a big part in venous disease. Those roles where you are standing for long periods of time, chefs, people in theatres, multiple pregnancy as well, that also puts a lot of strain on those vessels, which again can lead to venous disease. Underlying indicators of arterial disease. So these are much more punched out. For the patients, they've often had cardiovascular problems. They may have had a stroke, MI, they may suffer with angina. And those indicators of arterial disease, so that intermittent claudication, that cramping feeling when they're walking. Whenever I used to assess patients, you know, it would be, where are you sleeping at night? Do you sleep in a bed? And if they sort of indicated that they went to bed, but then they got really bad cramp or pain in their legs when they laid horizontal, but that was eased when they took their legs out of the bed, again, that was quite a good indication that, you know, they had poor circulation. Cold extremities, because that blood's not being able to get down there efficiently, it can cause, you know, cold extremities, very cold toes, discolored toes, and also that thick and slow growing toenails, because the blood's not getting down to where it needs to go, the nails aren't growing. Dependent rubor, so that's where the leg's really, really bright red. And then when you lift up the leg, it goes really pale. And that's just where all that blood's just sitting in the foot. You'll get absent foot pulses with arterial disease, pale and shiny hairless skin, again, because that blood's not getting down there. So the hair falls out, and the ulcers tend to be very deep and punched out. And they're more common on the lateral or malleolus and dorsum of the foot. Some of the medical conditions that make people more at risk. So you've got that hypertension, diabetes, and also hormonal, and also lifestyle. So people that smoke or have high cholesterol, obese. So these are all your indicators. So when you're looking at your patients with a wound on their leg, sometimes when you look at the risk factors and the indications, that will give you some sort of guide as to whether they sit within that venous disease or arterial disease. So when we're looking at that wound bed assessment, we're looking at what tissue types in that wound bed. Is it necrotic? Is it sloughy? Is it granulating? Is it epithelializing? And this is really important to document what type of tissues in that wound bed, because it all indicates different things. Obviously, we'd like to see nice granulating tissue and epithelializing where those edges of the wound are coming across. If there's necrotic or sloughy tissue present, we need to make sure that we've got a plan in place to be removing that. We need to look at the exudate. Is it dry, or is the volume very high? Is that exudate causing any maceration. What's the consistency of that exudate? Is it thin and watery, or is it thick, indicating maybe more purulent, more thick, pussy cells in that exudate? And then we look at the colour. Is it clear, cloudy? Again, all of these things give you indications of what's going on in that wound bed. We look for signs of infection. So we know those local signs of infection: increased pain, erythema, edema, local warmth, increased exudate, all these signs of local infection. And we need to then document that and put in place some treatment that's going to manage that. And then if that local infection isn't managed, it then turns into that spreading or systemic infection. So again, your patients will become increasingly unwell. They'll present with pyrexia. There might be abscess or pus, wound breakdown. And often when you get to that sort of spreading or systemic stage, the patients often say, I just don't feel right. Something's not right. And again, those are your indications that that patient's sort of more at risk of systemic infection. Then we move along to that wound edge. So like I said before, we need to look at each aspect of that wound when we're assessing it. So when we're looking at the wound bed, we're looking to see, is there any maceration present? Is that exudate causing that skin to break down at the wound edge? Is there any undermining? If there is undermining, we need to make sure that we've assessed it, we've measured it, and that we're aware where that undermining is going. Is the wound very dry? Is there dehydration? Do we need to add in some moisture to that wound edge? Because when it's got a very, very dry wound edge, those epithelial cells won't be able to migrate across and close that wound. Instead, they end up burrowing down because they haven't got that moisture. Epithelial cells need moisture to sort of leapfrog over each other. If it's dry, like the Sahara, they just can't do that. And then you've got your rolled edges, really hard to manage. Sometimes they need surgical intervention because if they become really rolled, they're really, really hard to get rid of. But we need to make sure that when we are looking at our wound edges, that when we're cleansing and debriding, that we give those the attention to make sure we don't get that crusting, which also can lead to those rolled edges. Sometimes also with rolled edges, they can be a sign of squamous cell carcinomas and things like that. So if those rolled edges aren't resolving with normal treatment, it may be worth referring to dermatology for further investigation. And then we look at that peri-wound skin. So again, we're looking at that maceration. So on this photo, you can see you've got lots and lots of maceration around the wound edge, but then also down to the heel, you can see that maceration. It's sodden. It's so full of moisture, and that skin's just breaking down. Excoriation, dry skin, that hyperkeratosis. Again, it all needs management because you're not going to heal that wound if that peri-wound skin's all breaking down and it's not healthy. Looking at that callus, that's it looks like it's on a Charcot foot. It's a diabetic related injury, but that callus needs to be removed because that wound's not going to progress while that's sitting there. And then you've also got your eczema. You may also need to do further investigations to aid that diagnosis. So you might do a full blood screen, a wound swab. An ABPI is needed for leg ulcers, and your pressure perception, which is that to see what the sensory neuropathy is. And you would follow your local guidelines as to when you would do your wound swab. But generally, for non-healing wounds, you would try to do that wound swab along the guidelines of your trust or area you're working. And now we move on to the National Wound Care Strategy Programme recommendations for that immediate and necessary care. So if you're not familiar with this and you manage patients with leg ulcers, really important that you read this. So sorry, let's just get this back up. Oh, it's not in here. It's all gone. should I do? Just put it on here. Resume. Oh, wait there. Is that it? Ah, okay. Sorry, IT issues. IT is not my thing. So these are your red flags. So if your patient doesn't present with any of these red flags, you can give that immediate and necessary care of 20 millimeters of mercury compression. So that's your reduced compression, however you get that with the systems available to you from your formulary. So if your patient isn't presenting with any acute infection, any signs of sepsis, acute or suspected limb-threatening ischemia, suspected deep vein thrombosis, suspected skin cancer, or bleeding varicose veins, you can put that patient straight into 20 millimeters of mercury. And this is a really new way of thinking since these recommendations came out. And it's meaning that those patients are getting that appropriate care sooner, which is really, really important. After that immediate and necessary care, you then have to arrange for that comprehensive assessment within 2 weeks. So that means that within those 2 weeks after you've started that reduced compression, you need to do that full lower limb assessment. Once that full lower limb assessment's been completed within those 2 weeks, you will then know if that patient can go into strong compression of 40 millimeters of mercury. It's also important that you treat any wound infection, clean the wound and surrounding skin, and apply an emollient. Record with photos. Digital images are obviously the best. Apply a low adherent dressing with sufficient absorbency, because you don't want to be getting that maceration that we had on those previous photos. And for those without the red flag, offer that mild graduated compression. Like I say, get them straight into that reduced compression, 20 millimeters of compression, using whatever products are available to you from your formularies. So within that full assessment, within the 14 days, if there's suspected venous disease with an adequate arterial supply, refer to vascular services for diagnosis and intervention, and apply that strong compression therapy. If there's suspected venous disease and peripheral artery disease, so if the ABPI is less than 0.5, urgent referral to vascular. And again, it's really important that you're completing that full assessment within those 2 weeks. If you're unable to ascertain the etiologies, you need to refer on to other services. For example, it may be that there's lymphedema there, and you'll be able to refer to the lymphedema service. So the ABPI provides an index for the vessel competency by measuring the ratio of systolic blood pressure at the ankle and the arm. And that needs to be completed by a clinician that has the appropriate skills, has been signed off as competent. And if you've got those skills and you're doing it regularly, you'll be very familiar with what you're looking at in terms of your ABPI. So it's really important that if it's less than 0.5, it's suggesting there's arterial disease and you need that vascular assessment. If it's between 0.8 and 1.3, suggests that there's no evidence of significant arterial disease, and you need to be applying that strong compression of 40 millimeters of mercury, because that's the therapeutic level that you need to get to. That 20 millimeters of mercury is just that first aid. It's not for them to stay in for all the time. It's just for that first initial assessment. If it's greater than 1.3, it suggests arterial calcification. So compression may be used with caution, but you need to refer for a vascular assessment to have those vessels properly assessed. Greater than 0.5 to less than 0.8 suggests the presence of arterial disease or mixed arterial venous disease. Compression should be avoided, but reduced compression could be used. And then again, you just need to refer on to your specialist for advice and refer to vascular for a more thorough assessment. Once you've confirmed that action plan with the patient, it's working in collaboration, isn't it? It's working in partnership. So you need to explain what you're going to do, what any investigations may need to happen, Will there be a team involved or referral to other team members? And you need to detail that specific treatment and share it with your patient so that if they have any questions, they've got the opportunity to speak. Because by getting that patient involved and fully informed in why you're doing what needs to be done, they can then understand why they need those things to happen. So again, I'm referring back to the Coloplast 3-step approach. So that was step 1, assessment. So now we're going to move on to that step 2, which is prepare. So it's about doing that wound preparation to remove the barriers to healing and create that optimum healing environment. So this is prepare, step 2. So within your clinical practice, you face many challenges. So here we've got 3 examples. You've got that excess fibrin and slough on that first photo. Not only that, but there's also undermining. All of these things cause more complications to that wound. On the middle picture, we've got necrotic tissue, and there's a bacterial burden within that wound. You can see that erythema, and that needs to be addressed and managed. And on that last picture, you've got that hyperkeratosis. So you've got that excess skin cells that are sitting there, and they need to be removed to put that leg, that limb, in the best condition to be able to heal. Because sometimes with that hyperkeratosis, if it's not managed and it's not removed efficiently, you can get ulcers underneath it, and then that whole leg will break down. So we know that 80% of non-healing wounds contain biofilms, although there's more evidence coming out to suggest that 100% of non-healing wounds may contain biofilms. If you're familiar with biofilms, you'll know that it's that structured community of microorganisms that protect themselves with this polysaccharide substance, like a slime, so that then they're really well protected and they cause real issues within that wound bed. They're not visible to the eye, but signs of infection indicate that they're present. So if you're getting that delayed wound healing, increased exudate and slough, because they keep the wound in that inflammatory stage. If there's that erythema, malodor, and high bacterial load, there will be a biofilm present within that wound bed. So often when we think about biofilms, we think of umbrellas. So you've got these microorganisms with umbrellas that are protecting themselves. And whenever you're putting your antimicrobial dressing on, or you're trying to break them down, they've got these umbrellas protecting them. What you need to do is cleanse and debride and break down and stop that umbrella structure protecting them, so that then whatever you're using on that wound bed can be as effective as possible. So the international best practice for management of biofilm infection is that, you know, it's recognized that it's not a one-step solution, but you need to have regular and necessary wound cleansing and debridement. So that's why that first step is to prepare that wound. So cleanse and debride to reduce the number of microorganisms. And you also need to disrupt and remove that polysaccharide substance that the biofilm microorganisms are protecting themselves in. So with that good cleanse and debridement, you can disrupt it and remove some of those biofilms. So in this illustration, this is the all prep pad that's been used in this illustration. So that's mechanical debridement that will be disrupting and removing some of those biofilms. Then you need to apply a barrier dressing, and that will what you need that barrier dressing to do is to prevent that maceration. It needs to be able to manage the exudate and prevent recontamination. And again, on this slide, the dressing that's being illustrated here is that biotane silicone with 3D fit technology. So we know that it's going to be managing the exudate and it prevents that recontamination. And it is because it has that vertical absorption, it protects that peri-wound skin from maceration. And then you would move on to your infection management. So you would suppress those biofilm formations because they reform so quickly. You need to be able to suppress them and reduce the existing biofilms and microorganisms with that active agent in the dressing. We often use the analogy of when you brush your teeth. So if you run your tongue over your teeth now, you might feel there's a bit of like a coating on them. that's where those biofilms are reforming. And we brush our teeth in the morning, we brush our teeth in the evening, we maybe use tooth floss. So all of these things we're trying to remove and disrupt that biofilm that comes back into our mouth very, very quickly. So by removing those barriers to healing, by cleansing and doing that wound debridement, we can remove the barriers such as the slough, the non-viable tissue and the biofilms. This is a retrospective study, which again just illustrates that cleansing and debridement, it speeds up that wound healing. So this is specifically looking at diabetic foot ulcers. The original cohort study was of 312,000 wounds. But it just again illustrates that when the wound was debrided once every week, it healed in a mean time of 21 days. If it was debrided once every 2 weeks, it took an additional, it took 76 days for that wound to heal. So if you can heal your wounds 3 times quicker by debriding more regularly, I know as a patient, I would want my wound to be cleansed and debrided as much as possible so that that wound could progress. So there are different ways that you can do wound preparation. So we've got here, so we've got washing and cleansing. So those are the green ones on the top. So washing the skin and the limb to maintain a healthy environment. Cleansing, so just removal of the loose surface surfactants. And then we move on to our autolytic, mechanical, biological and enzymatic. So these don't require extended competencies and training, but they do require some knowledge and skills. So with autolytic debridement, that's where the body removes that devitalized tissue by the use of moisture. So it's encouraging and doing that moist wound healing. So the body's enzymes in the exudate actually break down and separate that necrotic tissue. Mechanical debridement, like I've spoken about, is that all prep pad is our mechanical debridement within Coloplast, and it's that physical removal of the devitalized tissue using friction. So it's using the debridement pads to remove and break down that biofilm. There's biological debridement, so that's using larvae and maggots. Enzymatic, so that's ointment gel and dressings. And then there's also sharp and surgical debridement. But again, for this, you need extended skills, competencies, capabilities, and expertise. So if you need a wound to be surgically debrided, you would have to refer either onto another specialty unless you've got those skills yourself. So the National Wound Care Strategy Programme recommends the wound and surrounding skin are cleansed and debrided regularly. It is down to your own clinical judgment how often it should be done, but like I showed on the previous slide, it has been shown that the more regular and the more cleansing and debridement that takes place, the quicker the wounds will heal. So it's down to your clinical assessment when you remove that dressing and look at that wound. It's also down to the patient's pain levels, and if they're in too much pain to tolerate it, then you need to manage their analgesia before trying to address that wound preparation, because if you go near them and you're trying to cleanse it and they're hitting the roof because they're in so much pain, they're not going to let you go near them with anything. So you really need to manage patients' pain as much as possible. There are times you won't do debridement. So if a patient has a wound on a lower limb and is known to be diabetic, you may need to require some more specialist advice. If the patient has known arterial flow concern, again, get some more specialist advice. And also if they're immunosuppressed due to medications or underlying medical conditions. And I would also say if they've got sort of like fungating tumours, again, you need to either get some more specialist advice or use with caution. So we've done step 1 and step 2 of the Coloplast 3-step approach. So we've done our assessment. We've done that really robust assessment, looking at every aspect of the patient, the wound bed, the wound edge and the peri-wound skin. We've done wound preparation. So prepare using mechanical debridement, like I say, is our product within the Coloplast portfolio. And why it's really important to remove those barriers to healing by creating that optimum healing. And now we're going to move on to treat. So wound assessment and preparation leads us to identify our objectives for that wound. So what are we trying to do? Are we trying to reduce exudate or exudate pooling? Do we need to protect that peri-wound skin? Is there maceration or excoriation present? How are we going to manage that? Is there depth or to the wound? Is there cavity undermining? How are we going to manage that? Are there any signs of infection, whether that be subtle signs of localized infection, or is there those more classic signs of infection, spreading or systemic? But remember, the most important thing is identifying and treating those underlying causes. There are many different dressing types available, so it's about knowing what's on your formulary or what you're able to get hold of. But some of the commonly used dressings can be broken down into different categories. So we've got foams, antimicrobials, hydrocolloids, contact layers, gelling fibres, alginates, polythene film, odor absorbing, and hydrogel. So it's really important that once you've found your treatment objectives, that you're familiar with what products you have available to you and how they work. The National Wound Care Strategy Programme recommends the application of a simple, low adherent dressing with sufficient absorbency. And here you can see illustrated the Biotane silicone with 3D fit technology, and you can see where it's conformed to the wound bed, where there's undulating wound bed, but still that foam's conformed to it to ensure that there's no maceration and that exudate's been taken away from the wound bed, optimizing that wound healing environment. So when we're thinking about our leg ulcers and we're looking at that strong compression, it can be achieved with hosiery kits. So the National Wound Care Strategy advise using hosiery kits where you've got a good limb shape to be able to achieve that strong compression. The kits consist of 2 garments designed to be worn one on top of the other. Most kits contain 2 liners and 1 stocking so that one of the liners can be washed while the other one's being worn. And they're designed to deliver that 40 millimeters of mercury of pressure at the ankle, reducing to 20 millimeters at the calf. And the recommendation is for it to be worn for 24 hours, but the outer layer can be removed at night, but ideally wear it for the 24 hours while you've got an active ulcer present. And they can be available in off-the-shelf forms or made to measure. So here is just an illustration of where that assess, prepare, treat has helped a patient. It's a case study about a Mr. H. So this patient is a 90-year-old male with no comorbidities. He had a mixed etiology leg ulcer and been present for more than 10 years. His ABPI was outside the normal perimeter, so he wasn't suitable for full compression. The patient hadn't been confident to travel since having the wound. So for 10 years, he hadn't travelled. Although he really wanted to, he didn't feel confident enough to go and travel. So he was 90 years old. So from 80 to 90, he didn't travel due to this wound. So an assessment was carried out to find those management goals. The management goals were to create that optimal healing environment by preparing the wound bed, wound edge, and peri-wound skin. So remove that non-viable tissue, manage the exudate, manage bacterial burden, protect the granulation and epithelial tissue, and protect the skin. Then we went on to the prepare stage, and that was carried out using the all prep pad. And then for the treatment, he had Biotane AG non-adhesive. So when you look at those 3 pictures, you can see on day 1 that the wound's not looking healthy. That wound bed is very dark coloured. There's a bioburden present. On day 3, you can see there's been quite a change and an improvement within that. And then on day 54, the wound's healed and there's just some excoriation remaining. So the results were Over more than 10 years of care, Mr. H had found wound preparation too painful to tolerate. Since introducing All Prep Pad, which could be tolerated, his wound has made visible and significant progression. He was able to tolerate a 10mm of mercury compression liner after day 3, which he couldn't have done before due to his pain and exudate. So after 3 days after having that wound preparation, he was able to have that 10mm of mercury compression. After managing infection and exudate levels with Biotane AG, non-adhesive, he was able to share his care. So again, when we're looking at supported self-management, this easy, simplified 3-step approach really can help you implement that into your clinical practice with patients that are able to go on to that supported self-management regime. After managing the infection and exudate levels, he was able to share his care, and he had a Biotane silicone and hosiery at that point. And then the wound healed after 54 days of treatment. So after having this wound for 10 years and not being able to travel, after 54 days, that wound was healed. And I'm pretty sure he did go on holiday. Yeah, I'm just getting it confirmed by Charlie. Yeah, so then he was able to go on holiday. So that's a really positive story and just illustrates how this simplified approach can be used in clinical practice and the results that can be seen. So again, I'm just looking again at clinical practice and just highlighting how this simplified framework can get really, really good results. So at Coloplast, we've done a 60 patient evaluation. Out of the 60 patient evaluation, 4 patients were identified as having simple leg ulcers, and 32 were identified as having complex leg ulcers. So for the to help us define that complex leg ulcers, it was if they had one or more of the following. So if they had one or more of the following, then they were seen as having a complex leg ulcer. So a wound surface area more than 100 centimeters squared. If they'd had that leg ulcer for more than 6 months, not improved or reduced by 40% within 4 weeks, despite following best practice, ABPI outside of the normal range, current infection or history of infections, history of non-concordance, an active ulcer with one measurement between 2 to 6 centimeters, and comorbidities including peripheral arterial disease, diabetes, sickle cell anemia, self-harm, IVDU, rheumatoid arthritis, immunocompromised, and mobility restrictions. So if the patient had one or more of the following, they were seen as having a complex leg ulcer. So the overall leg ulcer results, this is including simple, complex, and increased complexity leg ulcers. So the average wound duration was 73.2 weeks. Average healing time following the implementation, sorry, I need to put my teeth back in, was 6.5 weeks. So the average time these patients came to the clinic had their wounds for 73 weeks, and they were healed within an average of 6.5 weeks, utilizing the Coloplast 3-step approach of assess, prepare with All Prep Pad, and treat with Coloplast portfolio of products with 3D FIC technology. Out of the 34 patients with leg ulcers, 79% of the patients healed. No patients received any antibiotics during that evaluation period. So you can see this simplified framework really does get those great outcomes for our patients. When we looked at just the simple leg ulcer results, they had on average the wounds for 8.75 weeks, and they were healed in 3 weeks following that assess, prepare, and treat, and 100% of the patient healed. Again, no patients received any antibiotics during the evaluation period. And when we look at the complex leg ulcer results, they had the leg ulcers for an average of 39.23 weeks. And again, they were healed in 6.3 weeks using assess, prepare, treat, and 91% of the patients healed and nobody received antibiotics. So I think, you know, this is actually giving you that data and evidence to show that this framework really does get the results, and it is a simplified approach. So any healthcare professionals can follow this simplified approach. You don't need additional skills. You just need to do that full holistic assessment, prepare the wound with that mechanical debridement of the all-prep pad, and use a dressing with that 3D fit technology, and the healing rates speak for themselves, 6.3 weeks. So we've gone through the Coloplast 3-step approach of assess, prepare, and treat. And now this is just the last part we're going to go through, which is that venous leg ulcer pathway. So this will support you in your clinical practice. So it's a really simplified pathway to help you manage those patients with a venous leg ulcer. So you start at the top with your patient. Does the patient have signs of arterial insufficiency? If they do, you need to dress as per your local guidelines and refer to the specialist as appropriate. If they don't have any signs of arterial insufficiency, you need to do your ABPI. Looking at your results will tell you then what you need to do. If the wound is improving, you would do that holistic assessment. You make sure you prepare the wound and you choose an appropriate dressing. On the back of this pathway, there is actually a dressing selection guide, which again will help support you to improve that patient outcome, and giving you that really simplified information in one place. So it's really important that you prepare the wound for healing. You apply that compression where appropriate, and you follow your local guidelines. Here we have that simplified product choice like I talked about. So you've got your step 1, which is the assessment, your step 2, which is preparing using the all prep pad. So you can see the all prep pad there. If any of you haven't seen the all prep pad, it's got 2 sides. It's got a darker grey side, which is for disrupting and dislodging the biofilm and removing that devitalized tissue. And the lighter grey side has unique slits within that, which can absorb and take away that biofilm and devitalized tissue that's been removed from the wound bed. And then we've got our step 3, which is treat. So if you're using compression hosiery or leg wraps, if there's no infection present, you can use biotin silicone or biotin silicone light. If infection's present, you can use biotin silicone AG. And again, with these products, they can form down to the wound bed up to 2 centimeters deep. So if your wound is 2 centimeters or less, you just need to use the one dressing. Again, simplifying it for your patients, simplifying it for the clinicians. It helps with supported shared care as well. If your patients are experiencing pain, we also have within the Coloplast portfolio of products Biotain iBu. If your patient has compression bandaging, we've got Biotain silicone non-border or Biotain non-adhesive. If there's infection present, we've got Biotain AG non-adhesive. And again, if they're experiencing pain, we've got Biotain iBu. So again, after this session, you'll get this pathway to support you out in your clinical practice. Charlie's going to put in the chat a link. So if you want any more additional support on our products or services, if you complete the form, then one of the lovely team will contact you. They'll be able to share the pathway, go through any specifics you've got around the products that we've talked about on this webinar tonight, and any other details or anything you want to discuss. So there's a QR code if you're into QR codes, and you can scan that, or like I say, Charlie will have put something in the chat that you can click on. At Coloplast, we also have our Wound Care Conversations podcast. So again, if you're out driving in between patients or you like listening to podcasts, please do listen. We've got 5 out so far, and you can find them on all your normal podcast platforms: Apple, Spotify, Google, Audible. And we've got different sessions talking around different aspects of wound care. So if, like I say, if it's something that you'd like to listen to, please do look up wound care conversations. So I think that's it from me now. I'm just going to go to Charlie. I'll stop sharing my screen. Has that been much chat, Charlie? Anything going on?
No, Sam, we've got an extremely quiet bunch tonight. But that was an absolute brilliant presentation. And I have put the links in the chat for people for any future webinars that you want to sign up for. The links to Coloplast Professional, and I do believe you can listen to the podcast on Coloplast Professional as well. And I've also added the link to be able to speak to one of our specialist team for follow-up. You will be sent a recording of this webinar along with a certificate and the Ulcer pathway for those of you that are asking in the chat. But I think that's it. Thank you, Sam. I don't think there's any questions in the chat.
I think everyone's quiet because they want to get ready to go to the football. But I hope you've enjoyed it. Please do look up on Coloplast Professionals. Like Charlie said, we put on webinars every month. And I hope you found it useful for yourselves back in clinical practice. Thanks for joining us. Bye.